This lecture is over a very timely subject, overlay removable partial dentures. It is something that can often be used when people retain some of their teeth and have lost some from a periodontal situation or from caries, but where their bite has collapsed, and an overlay partial can come in handy to open the vertical dimension and still retain some of the teeth. The definition of an overlay partial denture is one that it is a prosthesis that covers and is partially supported by either natural teeth, tooth roots, or dental implant systems. Those patients who would benefit from overlay removable partial dentures fall into the following categories: patients with mal-related ridges, patients with unfavorable tongue positions, high muscle attachments or sharp ridges and undercuts, also patients with deep vertical bites, and patients who may encounter difficulty with stability or retention of conventional partials or complete dentures. Other people who would benefit from the overlay RPD are patients facing the loss of teeth in one arch while the other arch will have remaining natural teeth, patients with surgical defects from cancer or congenital problems, and then patients with the evidence of extreme wear often benefit from the overlay RPD. Overlay RPD indications include the following. There are acquired defects from, say, trauma, bruxism, or abrasion. And then there are also congenital defects like oligodontia, amelogenesis imperfecta, and dentinogenesis imperfecta. The reasoning behind the use of the overlay RPD is based upon the conservative management of the remaining dentition. One or more teeth may remain, but they may not be suitable for retentive abutments, for aesthetic reasons, or they may be compromised beyond restorability to a reasonable fashion. Yet, those teeth may lend themselves to valuable support for the removable partial denture. Here is an example of an extreme wear case that benefits from the use of an overlay RPD. Here's an introduction to our patient. The gentleman on the upper left is our patient. Here's what his mouth looks like. On the upper, he has a reasonable maxillary arch with sufficient bone height and width. On the lower, he has natural dentition that have been worn severely down to exposure of the pulps in some cases. The culprit there is a complete upper denture with porcelain teeth that has been worn for about 5 years. In order to do a thorough job, diagnosis is absolutely the key to treatment. So we will look at his medical history and his dental history, including caries charting, endodontic evaluation, perio-exam charting, radiographic evaluation, TMD examination, oral hygiene evaluation, and prosthodontic evaluation. The patient's medical history is rather insignificant, but he is seeing someone about stress. He does have a type A type of personality, as he describes it, and he's just recently gone through a divorce and is finding that his job is very stressful these days. His lower arch shows severe wear. He's wearing a maxillary denture with unglazed porcelain teeth. This is a typical finding when porcelain opposes natural dentition, be it from a crown, a bridge, or a denture. He clenches his teeth together when lifting heavy objects on the factory floor and while he's under stress at work. He always sleeps in his denture and upon awakening experiences the feeling of tired jaws. Our patient has been told by a significant other that he grinds his teeth while he's sleeping. Upon doing a caries charting, no caries was evident, and none was radiographically evident either. His perio record was free of pocketing, but there was definitely areas where he had a lack of attached gingiva around the roots of his teeth. The patient has a strong history of oral hygiene, good oral hygiene. This may partially account for the abrasion at the cervicals of the teeth, or possibly abfraction may contribute to account for the damage around these areas. There are questionable pulpal exposures which appear on the teeth with the arrows in the picture, but no radiographic findings revealed any type of periapical abscess around these teeth. The patient complained of tired jaws, but upon TMD examination, there was no significant findings as far as problems with the joints. Parafunctional activity was obviously present from clenching and bruxing. On prosthodontic evaluation, it was determined that the patient had a vertical dimension of occlusion that was possibly a little closed, but even though he did also exhibit the fact that the teeth on the mandibular arch had extruded some. In order to make a thorough diagnosis, we must mount this case and take diagnostic impressions that include one of the edentulous arch, one of the patient with his denture in place, and then one of the mandibular arch. This slide displays a summary of the medical and dental history of the patient. In deciding what to do with our patient about vertical dimension of occlusion, we have to assign the patient to one of the following categories. One is the category where he has excessive wear with loss of vertical dimension of occlusion. Category 2, he has excessive wear without loss of vertical dimension of occlusion, but still having space available for reconstruction. And category 3 is that the patient has excessive wear without loss of vertical dimension of occlusion and no space available for reconstruction. The advantages of an overlay RPD are bone maintenance. The bone does not resorb at the same rate under a tooth-supported prosthesis as it does when direct support comes from the bony ridges alone. Basal support is established by direct positive support from the teeth as well as the tissues. The retention can be both primary and secondary. We have some teeth remaining, so we can get primary retention via the clasping on those abutments. Stability is obtained by the RPD counteracting the lateral forces that are exerted in function of the prosthesis. The psychological advantage for some people is really very great. People can equate loss of teeth with aging, and this can psychologically affect them. Retention of even a couple of teeth under a prosthesis often makes the person feel much better about the prosthesis. We also maintain proprioception. Think about all those periodontal fibers that are remaining and talking to the brain and telling them where those teeth are positioned, which in effect they're positioning for mastication. Therefore, we get increased masticatory ability. Patient acceptance is relatively good for this type of procedure. There's a lot of metal, but usually the patient is more comfortable and they function better, and this outweighs that disadvantage. The aesthetics of the prosthesis can be more aesthetic than what they had when they came in for treatment, but it may not be as good as some of the very high-end treatments like fixed pros. For our patient, psychological advantage was very important. He did not want, though, to have these other procedures done, which was a disadvantage. Some of the disadvantages of the overlay removable partial denture is the additional time that it takes to actually do a case like this. It can be quite involved, depending on how many root canals and various tooth preparations that you need to do. It is definitely more sophisticated and exacting for the dentist and the laboratory technician. Sometimes telescopic copings are involved, or Sometimes attachments are involved, and this makes the case more complicated, and attention to detail is absolutely critical if you're going to have a successful case like this. The teeth are susceptible to dental caries to some extent because if they don't clean properly, being covered by the prosthesis and inability to get to the teeth is a problem. Also, susceptibility, according to research, is higher for periodontal disease when you have overlay dentures. It requires increased maintenance and recall appointments. This patient doesn't just get this prosthesis and leave your practice for 5 years. They need to be coming in for more recall appointments to check on things. And obviously the cost is a lot higher when you're doing something like this. Both laboratory time and your treatment time is involved for a case like this. Whenever you treatment plan a patient, you should give them several options. You should not inject what you think about the financial condition of a patient on your treatment plans. You don't know that patient's dental IQ, and you often don't know what really priorities they put for dental treatment and how much they're willing to spend. For this patient, we could have had a maxillary CD and a crowns on all the existing teeth and add additional implants and have a retained fixed partial denture in the posterior area on the mandibular. There was also maxillary CD with splinted crowns on the lower and attachments on a mandibular RPD, precision attachments of some sort, so the clasp would be hidden. A maxillary CD with crowns on the mandibular teeth with just a removable partial denture. No precision attachments is an option. You could also have a maxillary CD with the overlay removable partial denture sitting on his remaining existing teeth. You could do a maxillary CD over denture, retaining a couple of teeth on the lower, say 2 canines, which we're getting, as we go down, the cost of these treatments is kind of decreasing. And lastly, we could have just plain old done a maxillary CD over a complete denture on the lower. And in today's treatment, this was done many years ago. In today's treatment, we would also add a whole slew of possible overlay dentures with implants or even fixed prostheses with implants, all of which would be quite expensive. But these are additional options using implants to restore both the upper and the lower arch. But options need to be given to this patient. The steps in the treatment plan, option 3, would be, first we would construct a bite guard for the patient to wear about 6 to 8 weeks to test vertical dimension. During that time, we could do our free gingival grafts on the first premolars bilaterally, the second premolar on the left, and the canine on the left. This option was highly recommended, but the patient refused to have this type of treatment done. We would also do endodontic therapy on all the questionable teeth where we see an evidence of a pulp chamber or residual pulp chamber, even though it appeared to be abraded over and secondary dentin taking its place. This would prevent future abscesses. The patient also declined, did not want the endodontic treatment done, even though he was informed of the consequences in the future. Then, after endodontic treatment would be done, we would do restorations on the endodontic teeth. That would range anywhere from amalgam caps in the pulp chambers to cast post with a coping placed over the root tip to prevent caries and other destruction. Then we would begin our maxillary and mandibular denture. We chose to put porcelain teeth on the maxillary complete denture and cover the partial denture framework, make the occlusal surfaces of that framework in porcelain also. As long as we have porcelain opposing porcelain, we will not have as much problem. The only questionable part here was his bruxism and whether or not that would be it would normally be done in acrylic, but we chose to do it in porcelain. The advantages of treatment option number 3, the overlay removable partial denture, are: the overlay partial is a totally reversible treatment. We will not be affecting the teeth in any way that is not necessary for any of those treatment plans that we talked about earlier, and it's a totally reversible. We will have slight preparation of the remaining teeth. Therefore, if the patient wants to go later with post and crowns, it's totally possible. By doing endodontic therapy to the teeth with questionable pulp exposures, we are preventing future abscesses from occurring, which would require endotherapy, which would change the anatomy of the tooth, and then it may affect the fit of the partial. Free gingival grafts being done prevent further recession around those teeth that have abrasion or erosion. The cost of the overlay partial is substantially less than option number 1, say, of fixed crowns. If we keep those teeth and place an overlay, the bone resorption will also be delayed. Think about also how much proprioception is provided by those periodontal fibers around those remaining teeth as compared to the complete denture. All those fibers will increase masticatory efficiency to the muscles of mastication. We can restore the vertical dimension to the patient, which should improve some of the temporomandibular joint symptoms that he's having, and possibly aesthetics. The plan can be more aesthetic than option number 1. The disadvantages of treatment option number 3 with the overlay are: the aesthetics are compromised when that prosthesis is removed. You would see those teeth that are in bad condition because they're not covered. They would be exposed to people seeing them. 2, the mandibular teeth may abscess if not endodontically treated. You saw those pulp chambers that were readily evident, even though there was no radiographic evidence of any abscess on each of those teeth. The teeth decay more easily under an overlay partial denture because of the metal coverage, plaque and debris being able to accumulate under and around it. And if poor oral hygiene exists, it can be a problem. This gentleman had good oral hygiene. The abraded or eroded teeth, if not restored, can have further damage, to which it may get into the pulp and cause abscesses in the future. Also, further recession of the gingiva under the below the teeth can be expected unless you have that periodontal surgery completed. And lastly, if any of these complications come about in the future, it may be a more costly treatment because you may have to do the endodontic therapy, the crowns of the teeth may be changed from the therapy, and therefore the partial would not fit any longer, and it can lead to further complications and cost. The steps that we're going to follow is: first, we're going to determine the vertical dimension of occlusion that we want. We're going to do some mouth preparations and take some master impressions. We'll make occlusion rims and adjust it to the trial vertical dimension of occlusion, or not to the trial, basically to our final vertical dimension of occlusion. And we're going to have the cast mounted, and we're going to have a maxillary denture try-in against some mandibular teeth set on an occlusion rim to make sure our vertical is what we're after. And then lastly, we are going to have the laboratory construct the framework against the maxillary teeth that are tried in, so that the anatomy of the porcelain teeth on the lowers that are created will match the maxillary complete denture. When we get our framework back, we will try in the occlusion rims with our teeth set up and use them to verify our centric relation record and, again, our vertical dimension. The two setup and the final try-in will be done, and then the trial dentures will be sent to be processed. Delivery of the prosthesis and care instructions will be done next, and finally adjustments on the case. This is our patient. Even though he's had those porcelain teeth on that ridge, you can see he still has a very nice ridge. The ridge has not worn down by any means, and it's not flabby and fibrous either. It's a pretty solid ridge. Here's what his initial case looks like, and you can see that the cause of all that wear is the natural teeth opposing porcelain teeth, and with his job he clenches quite a bit, and those teeth over the period of the 5 years that he's had that denture have had some severe wear. In reviewing the patient's medical history, it's rather insignificant. He does indicate, though, that he has the type A type of personality and that he's under a lot of stress these days. The patient has just recently gone through a nasty divorce, and he's been quite upset about that. His chief complaint is looseness of his maxillary complete denture and sensitive lower teeth to cold. He also wants to have a good appearance as he's now single and wants to be attractive to the female set. Here's what we see on the patient's 2 arches. And one thing you kind of think about is whether this patient could have combination syndrome. Combination syndrome has some factors. One, the mandibular teeth extrude out of the original plane of occlusion, and the maxillary arch becomes very flabby in the anterior. And as that happens also, the suction from the denture and the pressure on those anterior teeth puts excessive pressure on the posterior area as it's sort of rotating, and it pulls those maxillary tuberosities down out of the plane of occlusion. So you have to evaluate this as to whether this is part of the problem and see, you might treat it differently. You might have some tuberosity reduction in that type of case to be able to create decent planes of occlusion for this patient. In his case, the anterior ridge was very firm. I do believe that he had some extrusion of teeth, so whether you have a limited amount of space to actually change vertical dimension on a patient like this. But the tuberosities were not going to get into the way, I didn't think. So sometimes you can't determine this until you get occlusion rims in the mouth to try in and see whether you have room for a decent plane of occlusion. The first thing that we did was make a set of diagnostic casts. One was of the lower arch with the remaining natural teeth. The second one was of the actual maxillary denture, taking it out and putting it into some alginate. And thirdly, the actual maxillary arch itself. A jaw registration record was made on the patient so that I could mount the case, and then I arbitrarily opened vertical about 4 to 5 millimeters just to test vertical, and then we'll adjust it down as we experiment over the next few weeks, usually around 6 to 8 weeks. I made the bite guard out of triad material constructed on the mounted case, used a combination of the pink triad acrylic, and then also the resin is available in a white colored material. So I just sort of simulated some teeth to try and make it halfway aesthetic for the patient. You don't have many color choices when you do this with triad material, though. I adjusted the occlusion on the articulator, and then we took it to the mouth, and this is actually a picture after he had worn it for about 3 months. Adjusted the occlusion in the mouth and allowed him to wear it for a period of time. He really, really liked it because it felt good to his jaws, is what he indicated, possibly from the opening of the vertical dimension somewhat. We proceed with the steps for a complete denture from the point of having master cast, occlusion rims, determining vertical dimension with the bite guard, taking a record, making a record, and then mounting the case. At that point, the framework is sent off to be waxed up against the maxillary complete denture teeth so that the anatomy fits the anatomy of the denture tooth. Here is what our case looked like when it came back from the laboratory. You can see the nice anatomy that's in the lower denture teeth, even though it was kept to a minimal amount of anatomy because of his bruxism that was evident in his clenching. I didn't want real steep cusp. Here's a picture of the underside of the framework. It's all in metal, and the porcelain is baked to the metal. This was one very expensive framework, believe it me or on that one. It is absolutely critical that your impression be absolutely perfect, because look how intimately all this metal fits onto the cast, and the same thing has to happen when you take it to the mouth, which it did. Here's what the framework looked like in the mouth when it was tried in. It fit pretty well, but we did have to do some occlusal adjustment on the maxillary teeth in order to fit very well up against that framework. We tried in the frameworks, made some adjustments, sent it to the laboratory, had it processed, and this is the final processed dentures being delivered. Patient now will show some teeth. He wanted to show some teeth because he had felt like he had no teeth for a long period of time. So this is what it looks like from an occlusal view and from an anterior view. The patient has a little bit of an asymmetry. I don't know whether you noticed it on his very first pictures that we showed, but he kind of lifts the right side a little bit higher when he smiles than on his left side. But this is aesthetically what it looked like at delivery. Here are some additional views. If you notice what I'm saying about that lip, and it's getting hung up on the teeth just a little bit. But he has fuller lips, if you can tell from this picture, and his profile looks more normal at this particular vertical dimension. There are some endodontic considerations here. In a wear case, often a tooth must be endodontically treated to make it short enough to use as an abutment for the overlay RPD. The teeth used as abutments for the overlay partial, if they're not endodontically treated, are going to have a high rate of developing dental abscesses. If at all possible, and the patient can afford the endo treatment and copings, it will protect the teeth from the oral environment to some extent, and they should be used when financially possible. This patient did not consider it possible financially for him to do this and was willing to take the risk. In the category of periodontal considerations, pocket depths greater than 3 millimeters are unfavorable when you're choosing overdenture abutments. A minimum of 5 millimeters of bone has to be present if you want a denture to be an overdenture abutment. Any tooth that's clinically mobile should be evaluated real carefully before you select it, and if it's extremely mobile, you need to decide whether it's from some type of traumatic occlusion, and if so, they may be usable. If not, you might as well or might consider condemning that tooth. Posterior molars should have a cleansable furcation if you're choosing them for an overdenture. And a zone of attached gingiva must exist. Less than 1 millimeter is considered a poor choice for an abutment of when you're talking about attached gingiva. Some considerations when you're trying to decide what to do for this patient from a oral health standpoint: be sure to instruct the patient on the proper use of plaque control techniques. Inform them of the consequences resulting from non-compliance or neglect. On this type of case, you need to schedule regular recall visits to check everything out. You can use Periodex or a generic product when it's indicated for periodontal health, and when you have something with like an overdenture, you can ask the patient to put a drop of gel cam in the area where the framework sits on the teeth in order to apply topical fluoride and hopefully enhance the health and cut down any chances of decay. This gentleman did not have decay in his teeth. He had just severe wear. When you decide to open vertical dimension, you have to be very careful because any open vertical dimension can result in trauma to the supporting tissues under that maxillary complete denture. Nothing's protecting that ridge. And if you have an open vertical dimension, the patient will be banging up against those teeth all the time. He'll have his teeth in contact, and resorption may take place in that area. You also have to worry about trauma to the supporting teeth. He'll be in contact again all the time, and you're worried about wear on the teeth, especially if it's plastic teeth. They're going to have more wear than you would find, say, on porcelain teeth. On porcelain teeth or plastic teeth, you would have a constant clicking of the teeth if you've invaded that freeway space and the patient can't rest his jaws and get them close enough together when he says certain sounds when speaking. Bruxing and clenching of the teeth is another scenario. Now, this gentleman already has that problem of clenching, and his jaws can get quite sore if your vertical dimension is open too much. And lastly, if a patient's bumping up against those teeth all the time or clenching, the ridges will get very sore, and the ridges will be resorbed from this excess amount of contact of the patient. In order to prevent zonal caries, excellent hygiene is absolutely necessary in a case like this. And some of the things that you can do are, one, give them a topical fluoride gel, like Gelcam, to be placed into the area of each abutment tooth after cleansing the prosthesis. That will apply fluoride and hopefully prevent the caries. Also, dietary counseling is indicated for those that are susceptible to dental caries. Coke drinkers, beware. Copings, if possible, should be used for coverage in a case like this if it's feasible, but it does add considerable cost to the final treatment if you do individual copings on these teeth, along with the root canal therapy required for these copings. Regular recall appointments should be set up for the removable partial overdenture case. When doing an overlay partial, you have to consider occlusion. All of the teeth have to have something holding them in position, be it the opposing denture or some type of an overlay part on top of it that prevents the teeth from extruding. If you do not, the unsupported teeth will extrude, especially if that patient never takes his prosthesis out of his mouth, and some won't because they like it better with the prosthesis in place. So the rule is, when the patient takes the prosthesis out, every tooth has to touch. When the patient has the prosthesis in, every tooth has to touch the opposing arch in some way, either against an overlay or against another natural tooth. Here's a case scenario that we did with a patient. This particular overlay partial denture was made, and it was a lingual bar major connector, and all of these posterior teeth were covered with the overlay. The tops of all of these teeth were made with metal as part of the framework that opened the vertical dimension on this patient. But the anterior teeth were not in contact with anything. This patient liked this prosthesis so much that they wore it 24 hours a day, 7 days a week for 5 years. When the patient finally had some type of a problem and they came in, when you took the prosthesis out of the mouth, the only things that contacted were these anterior teeth, because all of these teeth had extruded and come up to contact the maxillary anterior teeth, and none of the posterior teeth that were covered by the overlay prosthesis were in contact when the patient closed his mouth. This is a problem. You cannot design a prosthesis like this. You have to hold all those other teeth into position in some manner. Let's get back to our little case and see what happened to this particular gentleman. At about 26 months, that patient presented with a chip on the lingual cusp of his left first premolar on the prosthesis. We did an occlusal adjustment. That was done, smoothed off the little cusp tip, and he was comfortable. He still had occlusion on that particular tooth. At 5 years, the patient felt pain on his right second molar, and come to find out an abscess had occurred, which we said there's a high rate of abscess. And a root canal therapy was performed by someone else, and they ground on the top teeth, and then the partial denture no longer fit on that tooth. It kind of rocked over that area, and the patient was uncomfortable. What I did for this patient was I created a cast post on the tooth that was endodontically treated, and I made that cast post and waxed the pattern to fit the existing partial overlay denture. And then we delivered the denture again, few minor adjustments, and the patient was back in service on his overlay partial. Here's another case that I did a overlay removable partial on, and this is a gentleman that worked out at GE, and when he came in, this is what his bite looked like. I always thought of him as a rodent. If you know, those teeth on rodents will continue to grow on them, and this was a case where his total incisors totally occluded with the maxillary ridge. This is Mr. Smith, his upper and his lower arch. We're going to consider doing a removable partial denture to give this patient some teeth on the upper, and as you can see, you've got a big palatal torus, so obviously we'll be considering doing a horseshoe-shaped maxillary RPD on this particular patient. One thing that we'll consider based upon his occlusion is that we're going to want to do facings in the anterior area and then do some severe enamelplasty on those lower teeth in order to create enough space where the major connector can go anteriorly through that space and have some facings with him in occlusion with the actual metal plate of the partial denture. Here's an example of the framework wax pattern sent back from laboratory. I obviously did not communicate well with my laboratory, and they obviously didn't totally understand overlay removable partial dentures. I thought it would come back looking something like the one over on the right with the occlusal surfaces all covered with metal and occlusion waxed into the design. You need to have all of the teeth in occlusion with the opposing arch. Every tooth must be supported so that no tooth extrudes while wearing it. Here we have the final case. All of the occlusal surfaces are covered of the natural teeth, and you can see that we made some room. We don't have the same deep vertical bite, and all of the occlusal surfaces of the teeth are covered with the removable partial denture. That way his vertical is opened up. We could get through some metal and place facings or wraps in that area, and we end up with a real nice result for this particular patient, and he's able to function very successfully with this type of a partial denture. This is a side view of another case where we used the overlay RPD. You can see where the metal overlays the buccal cusp. This patient's anterior teeth were extremely mobile due to traumatic occlusion. The bite had collapsed and the mandibular anteriors were pushing the maxillary anteriors to the labial whenever she occluded. She did not want extractions. We had her wear a temporary overdenture until the anterior teeth tightened up. We then impressed and constructed the overlay RPD, which opened her bite slightly, and she had to wear it all of the time. She did not mind. She said she was actually much more comfortable with this partial denture in place. Here's a side view from the other side of the overlay. It's not really very aesthetically pleasing, but it is an option for treatment that is less expensive than crowning all of the teeth on the maxillary arch. Not everyone can afford the crown and bridge work. Here's the prosthesis from the occlusal view. Notice that all of the teeth are covered, and in fact, if you can notice, we've got some like little cingulum areas or a ledge built on the backs of these teeth so that the mandibular anterior teeth all have a positive stop to keep them from extruding when the partial denture is in position. This case is an example of an overlay partial denture that will cover the molar tooth root on the extension base side, which allows it to act almost like a bridge on that side. We'll see this in a second. This is the side that's been reduced. The patient has a posterior molar that may be compromised. It could be compromised from a perio standpoint. It could be endodontically treated, and you were considering extraction on the tooth. It doesn't have an abscess or anything like that. You can overlay that tooth with your partial extension base area, and it becomes more like a tooth-supported partial denture than an extension base or free end, providing valuable support for that partial in the posterior. Take a look at this older partial that has a Novus soft liner in it. That molar was compromised from a crown to root ratio, and it was cut off because it had endodontic therapy down to 3 millimeters above the mark of the gingiva. It has helped to support that partial for 9 years. That partial, being a tooth-supported partial, is so much more effective than a free end would have been if we extracted that tooth. Here's another case which gives you an idea of how the framework is constructed to cover the teeth that have been trimmed down. Take a look at the master cast and the finished prosthesis. The finished prosthesis is shown on the cast. Care must be taken to make sure that the acrylic resin is thick enough over your abutment teeth, or you may run the risk of fracture. This is our last example of the overlay removable partial denture patient. It shows a patient who has some severe wear, and we have a change in vertical dimension. We have decided to do the overlay partial denture on mandibular arch. So what we need to actually construct the prosthesis is to get a maxillary complete impression of the existing arch, or a denture if they were taking a denture, if they were wearing a denture, and an impression of the mandibular arch. The process we're using, we are going to make a face bow registration and a centric jaw relation record, and we're going to mount this case on the articulator. After we mount the case, we're going to take a look at it and decide how much we're going to open this case. And in this case, it is going to be about 3 millimeters. We will test the bite guard that is made and shown on this particular slide for a few weeks and determine whether the patient has any musculature problems due to the fact that we're opening the vertical dimension by about 3 millimeters. We adjust this bite guard in the mouth so that all the teeth are touching in centric and in left and right working motions. Here's a description of the tentative design that we have for our partial denture. We're going to do minimal rest preparation so that when the patient takes the prosthesis out at night, it is at the original vertical dimension of occlusion. We will test the bite guard that is made and shown on this particular slide for a few weeks and determine whether the patient has any musculature problems due to the fact that we're opening the vertical dimension by about 3 millimeters. We adjust this bite guard in the mouth so that all the teeth are touching in centric and in left and right working motions. When you are going to obtain your centric jaw relation record, how do you know what the same vertical dimension is that you tested during your trial? One way of obtaining that CJR record is to make an anterior jig, and it's made with the bite guard in place by placing some compound in the anterior area and having the patient occlude on his bite guard. That way, this particular record opens those anteriors to the same point that you had at your end testing date. Next, you remove the bite guard and you get a jaw registration with material that is placed in the mouth with the jig in place marking the position of the mandible. So in the posterior area you might put something like a blue mousse or a Regisil, some type of recording medium for the vertical dimension and CJR record. These records are used to mount the case. The final design is placed on the cast and a prescription is written and the case is sent to the laboratory for one final framework. Remember, a consideration is that you want to prevent all of the teeth from extruding, and if you notice, those posteriors are totally covered by metal, but you want to prevent the anteriors from extruding also. On the mandibular arch, the way you would do that then would be to put some little cingulum rest on the remaining teeth and do lingual plating, which will prevent those teeth from extruding when a person is wearing the bite guard. Here's the final wax pattern for this overlay partial. I always like to take a look at it to see what we're going to get into because this becomes a pretty expensive partial denture. The final framework is tried in the mouth and an occlusion rim of wax is added to the edentulous area on the framework in order to get a jaw registration. On this particular case, we sent it off to the laboratory. We didn't have a try-in because everything was pretty set and had the teeth set and the denture processed. Here's the final partial delivered. The centric relation and contacts and excursive movements are all checked and it's just fine. There is a flaw in this particular design though. There is nothing that prevents the maxillary teeth from extruding and moving downward into contact with those mandibular anterior teeth. You cannot always assume that that patient is going to take that prosthesis out at least 10 hours a night or something to that effect, and that the natural teeth will come back into their positions. So this patient wore it 24/7, and we had a problem. If the patient wears this 24/7, the anterior teeth will extrude into occlusion, and the patient will eventually not be able to get his back teeth together if the partial is damaged or lost. This will cause destruction of the anteriors. This is what happened in this particular patient's case. When she came back in to see us, nothing in the back touched when she closed her teeth together. We thought she would be removing this at night, and she did not. So the bottom line is, if you get anything out of this particular presentation, that partial denture that is an overlay has to be designed in such a way to have all the teeth in the opposing arch in contact so as to avoid a problem where teeth extrude because there's lack of contact.